Hello everyone. Today we will discuss regarding endemic goiter. So what is the learning objective? So you should know how to define a goiter and what constitutes an endemic goiter, how is it different from other forms of goiter, the etiology and the pathophysiology, the clinical features and WHO grading of goiter and what are the investigations that needs to be done in case of suspected endemic goiter, then what are the iron-rich foods that are available locally and about the National Iodine Deficiency Disorder Control Program. What is a goiter? Goiter is abnormal enlargement of thyroid gland situated in front of the neck. It may result from physiological, autoimmune, or nutritional causes. So, according to the functions, it can be called as euthyroid, where there will be normal hormone levels, but the thyroid gland will be enlarged, or hypothyroid, where there will be decreased hormone levels, but the thyroid gland will be enlarged, or hyperthyroid, wherein there will be excess of hormone as well as excess of glandular structure. So, what is endemic goiter? Endemic goiter occurs in population of specific geographic region where iodine deficiency is prevalent. If greater than 10% of school age children shows thyroid enlargement, then the area is considered as endemic. It indicates widespread iodine deficiency in the community. So, what are the causes of endemic goiter? The primary cause is due to iodine deficiency. This alone constitutes 90% of endemic goiter. Then, prevalence of more goitrogenic food in the diet like cassava, cabbage, ragi, or soya beans. Environmental leaching of iodine from soil by rainfall or floods can result in iodine deficiency in the soil, resulting in poor iodine consumption in the diet. That is why you often tend to see no cases of endemic goiter along the seashores or in the fisherman community because they have taken a rich iodine diet. Then deficiency of selenium, iron, and vitamin A can also predispose to iodine deficiency in addition to genetic predisposition and low socioeconomic status as well as awareness levels. Coming to the pathophysiology. So there will be low iodine intake which will result in reduced T3 and T4 levels because of the feedback loop. The pituitary gland will increase the secretion of TSH and TSH will then instruct the thyroid gland to secrete more hormones, which will result in hypertrophy and hyperplasia. So initially, this will be diffuse in nature. Later, this will develop into nodular thing. Chronic stimulation may produce multinodular or even toxic goiter. So to sum it up, iodine deficiency result in pituitary stimulation, result in follicular hyperplasia, resulting in neck swelling. So the clinical features. In general, there will be visible, palpable neck swelling that moves with the swallowing, then diffuse in early stages and nodular in later stages. Usually, this swelling is painless. Pressure symptoms may occur at later stage, causing dysphagia, dyspnea, and hoarseness of voice. Maybe euthyroid, hypothyroid, or hyperthyroid. So, how it affects in different age groups. So, in children, it causes growth retardation, low IQ, and cretinism. In adolescents, it causes pubertal enlargement and menstrual irregularities. In adults, it causes pressure symptoms and hypothyroidism. In pregnant women, it can cause miscarriage, stillbirth, congenital hypothyroidism. In lactating women, there will be low iodine content in women, resulting in hypothyroidism in children. Both it will result in congenital hypothyroidism as well as cretinism. Then, in elderly, there will be retrosternal extension, toxic multinodular goiter will be present. So, the examination findings, there will be a midline swelling that moves with the swallowing. When you do palpitation, you can assess the size. You have to assess the size, consistency, tenderness, and nodularity. In percussion, there will be retrosternal dullness. In auscultation, systolic bruit in case of toxic goiter only. Then systemic examination for hypo and hyperthyroid signs. So this is what is a case of giant goiter. So how WHO grades goiter? So when there are four grades, grade 0, 1, 2, 3. So when there is no palpable or visible goiter, but it is only present in lab results showing elevated elevated TSH levels, but decrease in T3 or T4, then we call it as grade 0 when there is no visible swelling. When the goiter is palpable but not visible when the neck is in normal position. In grade 2, visible swelling in the neck even when it is in the normal position. In grade 3, very pronounced swelling visible from a distance. So this is an example of grade 3 goiter as per WHO classification. So what are all the investigations we can do? We can do an urine iodine excretion test for iodine, then serum thyroglobulin elevated in deficiency, FNAC to rule out any malignancy, then thyroid function test T4 and TSH, then ultrasound to assess the volume and nodularity, Then population surveys to check whether it is an endemic goiter by doing school surveys of enlargement of thyroid gland, and salt iodine testing also can be done. So now, what are all the rich foods, iodine-rich foods that are advised to take up in a case of goiter? So seafoods like fish, prawn, crabs are rich in iodine. Then seaweeds like kelp and nori. Contents like milk, curd, paneer. Eggs can be taken, especially the yolk one. Vegetables, drumstick leaves and spinach can be taken. Then grains like ragi, rice in coastal regions can be taken because there will be rich in iodine. Iodine will be rich in soil. That is why this can be advised only in coastal regions. Then adding iodized salt after cooking to avoid iodine loss, prevention and control. So there will be universal salt iodization, which we call it as food fortification, where we do add the iodine into the salt at 30 parts per million at the production level and 15 parts per million at the household level. Then public awareness and IEC activities, regular monitoring of salt and urinary iodine, intersectoral coordination, periodic school and community service are required. So now, coming to National Iodine Deficiency Disorder Control Program, it was launched in 1962 as National Goiter Control Program and renamed in 1992 as National Iodine Deficiency Disorder Control Program. The objective is to reduce the iodine deficiency disorders to less than 5% in endemic areas, ensure universal access to iodine salt, conduct regular surveys and lab monitoring, promote public awareness and education. So components include universal salt iodization. That is why we always ask the consumers to buy iodized salt. Then monitoring and surveillance, health education and information education and communication, intersectoral coordination, legislation, that is a ban on non-iodized salt is required. And so far, we have achieved greater than 90% of Indian households consume only iodized salt. So, management of endemic goiter. So, if it is mild, that is iodized salt or iodine capsules itself is sufficient, and only few will require medical therapy like thyroxine therapy to suppress TSH. Surgical thing is indicated only in large or nodular goiters. Follow-up is required, and a regular thyroid function monitoring and nutritional counseling has to be done. Prognosis is excellent with early iodine supplementation, and neurological damage in cretinism is irreversible in case of children. That is why early diagnosis is quite important. So the take-home message is endemic goiter is a visible marker of community-wide iodine deficiency. It is preventable. Early detection ensures full recovery. Iodized salt is the simplest, cheapest, and most effective preventive measure. Pregnant and lactating women are high-risk group and need adequate iodine intake in their diet. Regular monitoring of salt iodine and urinary iodine levels are important to maintain sustained elimination. Public awareness and health education are key pillars of prevention, and eliminating iodine deficiency ensures normal growth, intelligence, productivity for future generations. I hope you have learned from this presentation. So thank you.